All right. All right. Well, welcome. My name is Kyle Kusinose. I am a physical therapist and director of the Jones Institute, and I'm here with Brian Tuckey, the director or the developer of Fascial Counterstrain, and we're doing another fascial counterstrain sort of live here. We're doing this one a little bit differently than we've done in the past. Previously, we've utilized Zoom, but we've streamed live to YouTube or Facebook, and we made this one specifically just in Zoom, or we decided to do it just in Zoom, so that one we can record and post it on our socials later, but also so that we have some Q&A functionality in here as well. So if you guys look on the bottom screen, you will see a Q&A, and it looks like some of you guys are using it already. So please, as we're going through the content today, feel free to type questions in there, and I will do my best to relay them to Brian so we can try and get all your questions answered. The other thing we're going to do a little bit differently today is kind of zoom in. We've been pretty broad with our previous topics, speaking more to what is fascial counterstrain, how can it help your practice, where to start with your education in fascial counterstrain. We're going to zoom in on the musculoskeletal system today, specifically on spinal ligaments, but a little bit on some of the myo chains as well. And in doing that, we hope to kind of shoot down the middle a little bit more and speak not only to prospective students or people that know nothing about this technique, but also some of you that have taken the courses previously and are maybe stuck in your clinical practice with implementing some of these techniques from either the Fascial Foundations course, the entry-level course for this curriculum, or in the more advanced course, the spinal ligaments course. So that's sort of our agenda for this evening, and then I'll let Brian introduce himself a little more thoroughly, and then we can get rolling here.
All right, thank you, Kyle. As Kyle said, I'm Brian Tuckey. I'm a board-certified specialist in outpatient orthopedics. I've been a therapist, manual therapist for about 35 years, and I'm one of the original 4 physical therapists that was certified to teach the osteopathic technique strain and counterstrain by Dr. Jones himself. And then he died shortly thereafter in 1999, and I kind of took the reins of development at the Jones Institute and really have expanded the technique from about 200 different treatments to what is now well over 1,000 different treatments, and also have expanded the assessment from a pure tender point palpation assessment to kind of a multi-step assessment process, which really allows us to zero in on the main areas of dysfunction rapidly. So as Kyle said, what we're going to talk about here is a little bit about the basics of the technique, because there are quite a few people who will watch this video who've just heard about the technique but have really no idea what it is, how it differs from other forms of treatment, manual therapies. And then we'll talk a little bit about some specific applications that are musculoskeletal, realizing that the real benefit of this technique is that it is, in fact, a multi-system technique that really addresses not only musculoskeletal tissues, but also visceral tissues, neural tissues, vascular tissues, and in the higher ends of the curriculum allows you to drain inflammation from the central nervous system, working on things like neurodegenerative type conditions and post-concussion syndrome, chronic fatigue syndrome, cognition loss, cranial nerve dysfunction, etc. So I think what we'll do, Kyle, is I'll pull up my PowerPoint and we'll go through a couple basic things and then maybe show a video or two for those who've never seen the technique in action.
Yeah, and it looks like we have about maybe 45 to 50 people, Brian, that just answered on the poll, saying that they are brand new to the technique. So,
All right. Yeah, I don't, let me see here. Let's see here. I don't seem to have our faces up here. What are you seeing there, Kyle?
I still see just you and I.
All right. Did something wrong there? Let's see here. So I think I got to reshare. Let me try that one more time.
There you go.
There we go. There we go. I'm getting rusty. It's been about a month since I did this, I think I would know. Right. Let's go here. And let's pull up our video panels here as well. Get those two. Sorry, everybody here. Show video panel. All right, there we go. Okay, so let's get going here. And I'm going to shrink that down here quite a bit. So what is fascial counterstrain? So probably the most simple definition of what this technique is that it's a complex process that identifies and removes trapped inflammation from the body. Okay, in its rudimentary form, that's what it is. And we all know that inflammation is the root of so much chronic disease, but we'll talk about the applications of it, as far as a fascial counterstrain practitioner. So then that would lead you to the obvious questions of where exactly is this inflammation chronically trapped? And then what are the symptoms, or conditions caused by that trapped inflammation? Okay. So let's talk here real quickly. If we look at the question of where it's trapped, and I'll have another slide coming in a moment, the answer is that it's in the newly discovered interstitium or microvascular system. So what is that? Well, basically, if you look at interstitial fluid or, lymphatic fluid, it's the clear fluid in your body. You could even call it blister fluid. So it's not in the bloodstream. So if you do lots of testing as far as, inflammatory tests in the blood, looking for like, C-reactive protein, things like that, you will not find it. So, fascial pain does not show up in the bloodstream. It's trapped in the interstitial space. What happens if inflammation is trapped in the interstitial space is that the first thing it does is it chemically sensitizes nociceptors. Okay, nociceptors, big word for pain receptors. So you can stimulate a nociceptor mechanically, thermally, or chemically. If there's trapped inflammation like cytokines or substance P, for example, that can an ongoing chemical irritant of the nociceptors and give you, of course, ongoing pain. Well, what else happens? Well, it turns out that these nociceptors go into the spinal cord and stimulate reflexes at that segmental level. So in this particular slide, and I pulled it out of our visceral class, here you have a triangular ligament of the liver. So the liver itself is suspended on the bottom of the diaphragm by visceral ligaments. They, in fact, do have nociceptors. That's where the injury is, where the inflammation is. And then those nociceptive signals go into the spinal cord and stimulate two main reflexes. But the first thing it can do, of course, is cause pain. If that stimulus is greater than the pain blocking system that descends, from the brainstem, you could experience pain. But it also stimulates muscle guarding reflexes. So the trapped inflammation stimulating the pain receptor triggers the muscles to guard in that area. So this could be lost range of motion. This could be a trigger point. This could be, a segmental motion loss. If you motion tested someone's spine, you'll feel that muscle guarding reflex. Secondary to the stimulated nociceptor, secondary to the trapped inflammation. Okay. Next, you also will get stimulation of somatosympathetic reflexes. So these same nociceptors go into the ventral horn, to the muscle guarding reflex, and the intermedial lateral column, into the autonomic area of the spinal cord, and it causes segmental vasoconstriction. And what that is, it's basically a vessel spasm. So the arteries constrict, the veins constrict, and that is an ongoing reflex arc if those nociceptors keep getting stimulated. So what could that do? Well, first of all, a vein in a state of contraction would cause chronic edema, for example. Okay, you could see lymphedema or, swollen ankle or just be inflamed in that area. Artery side, you're going to get less nutrition. So whatever that thing does, if it's an organ, it's a muscle, it'll be weak. Okay, and if that artery vasospasm continues over a long haul due to this reflex, you can start to get degeneration, trophic changes. Okay. So that's where you could see, for example, at one segment, a degenerative disc, but yet the other segments are okay. So that was an old trauma set in this nociceptive loop, vasoconstriction, things start to wear out prematurely. Okay. So there's, lots of discussion we'll go into in the classes on this. But those are some basic things I want you to understand before we move on. Trapped inflammation stimulates pain receptors. Yes, no on the pain side, but other things happen. That trigger point, segmental motion loss, long-term changes in degeneration or weakness can all be from the same trapped inflammation.
And right, just to back up for a second on the concept of sensitization, because I think it's an important one, especially with different pain mechanisms. People are going to recognize terms like peripheral sensitization and central sensitization now. Um, but what chronic pro-inflammatory cytokines on neurons do is sensitize them, meaning lowering the threshold for action potential propagation. So it makes it so that neuron can fire with significantly less stimulus than it would have otherwise.
Right,
Uh,
exactly.
and that's important in how many steps of this process that you just outlined, um, from the initial nociceptor, peripheral nociceptor into the DRG, dorsal horn, and up into the brainstem. There, you can sensitize all along the way.
Yeah, and then so central sensitization, we can have a vasoconstriction of, for example, one of the spinal drainage pathways. Okay, so we can get an epidural vein, we could get a anterior posterior spinal vein, and then you can get inflammation at the spinal cord level or up in one of the pain sensing areas like, the medulla or the thalamus of the brainstem. Then you get widespread nociception and, hyperalgesia. Even allodynia, just touch and ow.
Yeah.
But so what we're going through here, as Kyle just, chimed in, is that this is the very simplified local loop, but this could be a much more widespread phenomenon depending on where that swelling is trapped. Okay. And we address that as well, even starting in the first class, we do some spinal drainage techniques. All right. So what we got here is a video of a patient who was a very chronic pain patient, was treated by one of my students at the time, multiple surgeries, 3 or 4 surgeries, 4 or 5 years of chronic pain, met the student on a walker, and she got him to this point, and she was kind of stuck, hadn't taken some of the musculoskeletal stuff at that time. So when she sent this particular patient up, she had cleared out several systems, having taken several classes, but the spinal ligaments and the myochains, which is what we're going to talk about today, were not addressed. So you're going to see a real nice pure case, having peeled off some of the other types of fascial dysfunction already, of a musculoskeletal case and what that can do for you. And you also see at the end, the carryover of this paradigm. Since we're identifying the root cause of the problem, not the surface reflex symptoms, we have outstanding carryover with fascial counterstrain, particularly as you get more and more skills. So you'll see at the end of this video, I bring him back 6 weeks later, and everything we did in this 20, 30-minute little session here has maintained. Ward has had multiple surgeries in his back, has had quite a bit of counterstrain performed. The viscera is clear, several other systems are clear, but he is a pretty strong musculo-ligamentous pattern, and we're going to see how poor his motion is in flexion and straight leg raise. So go ahead, Vince, bend forward to feel tightness. And move you around your back there, you start down pain, everything. Okay, so you can see that's not quite where you want to be. One more time, again, what do you have comfortably? Okay, and you feel that through the back, hamstrings, everywhere?
Yes.
Okay, all right. And go ahead and lay your back there. We'll check the straight leg raise. And then we just check the straight leg raise. He has about 45 degrees. He's already wincing there. Right about there?
Yeah.
Okay, maybe actually it's about 30 degrees of straight leg raise. And the other side. Right there. Okay, all right. And so you've had laminectomies at 1, 2, 3, 4, and 5.
2, 3, 4, 5.
2, 3, 4, 5.
One's the only one left.
One's left. Okay. All right. Thank you. Okay. So it's about 25 minutes later, and what we found were anterior longitudinal ligament dysfunctions in the lumbar spine, posterior longitudinal ligament dysfunctions, and some pretty severe lower extremity muscle chains all the way down into the ankles. And then we're going to reassess his straight leg raise and trunk motion. So you tell me when, Vince, if you have any pain. We're going to bring it up again.
Good.
Still good?
Yep.
Okay. Yeah, right about
There.
there. Okay. Definitely better?
Mm-hmm.
Okay. All right. Good. We'll come back down. So that was about 30, and we were about 80. And then the other side was a little better, about 40. And we're going to bring this up. Yeah, I'm still free. That one's all the way up to 90. All right. Excellent. How long has it been since you had that kind of motion?
Can't remember.
Can't remember? So before the first surgery, probably?
Yeah.
Okay. All right, let's see how your trunk motion is. When was the last time you could bend all the way over?
Can't remember.
Can't remember. Okay, well, let's see what you can do. How you feel?
Good.
Good, no pain?
Nope.
And so just a little hamstring, maybe?
Mm-hmm.
All right, put your hands down, see how far you can go. So, wow. So that was even more than I thought it was going to be. All right, outstanding. Okay, we're 6 weeks later back with Vincent after his last treatment. He reports maintaining all the motion improvement and has returned for one little spot on his right iliac crest. We're just going to show you a pre-treatment range of motion test to show that the gains were maintained. So go ahead and bend forward for me. And there he goes. And let's see, can you touch the ground for us? All the way down to the fingertips. Excellent. And come back. And what did you feel there?
Nothing.
Nothing.
Good.
So, all right. Great. Thank you. All right. So let me pull this back up here. So then the next question would be, we can talk a little bit about that video first, but so the idea is we want to identify, again, the root source, which is trapped inflammation. We will, in the courses, get into, how it actually traps, talking about expression of things like TGF-beta 1, which is a cytokine produced by myofibroblasts that then actually cause tissue contraction, which can create an area of stasis. We'll get into all that. At the end of this, we'll even throw up a published article where this entire paradigm of stasis, of inflammatory stasis and impaired lymphatic drainage has been published in a major journal in 2021. And it's 147 citations, 6,300 words to explain this at the high level. So a little complex, but I'm giving you guys enough to really understand. But again, get into the root cause so we don't have to redo this. So this is not something where we go to the muscle guarding reflex on the surface and then stick our elbow in it or, use some of the, tools or try and massage it over and over again. We go to the nociceptive source, chemical source of what, told that muscle to contract. Okay. So muscles can be primary, but many times they are just the body's guarding mechanism. And if you treat them, you'll soften them up a little bit, but it's going to come back unless you find the source. So that's the next thing we're talking about here. Where is the source? And in 2018, this article came out by Benias et al. And it basically was using CLE, confocal laser endomicroscopy, which was a new tool that you can kind of go in vivo and really see at a very small level tissues. And what they found was this flowing channels of pre-lymphatic fluid and basically this microvascular system, smaller than anything that had previously been identified. And again, clear fluid, lymphatic fluid. And you'll say, well, where were this flowing matrix that you can kind of see over here? Well, the answer was pretty much everywhere. Okay, so they found it around all fascial tissues, all ligaments, all tendons, all myofascia, but also, as you can see here in the PowerPoint, around the gastrointestinal tract, all the viscera, the urinary bladder, the dermis, superficial fascia area, peribronchial, periarterial, perineural. So it's basically ubiquitous. It's everywhere. And that means that you can have trapped inflammation stimulating virtually any type of nociceptor. And that is why the technique is multi-system. So what we really do is find those areas. We're going to decompress the tissue. We'll show you a slide, create a negative vacuum that allows all that to drain out into the lymphatics and off it goes. Okay. So the process is, where's the inflammation, tender points, and our diagnostic process tells us that. And it tells us what tissue to decompress to get rid of that deep, underlying inflammation. Now, is there any evidence to say that this inflammation is in fact trapped in that interstitial space? Yes, if you look at this study here, it's a very famous study that's been cited so many times now. 2008, J.P. Shah, Dr. Shah, personal friend of mine, did a study where he took a microdialysis needle, a tiny, tiny little needle, stuck it into an active trapezius trigger point, and was able to draw out the interstitial clear fluid without the blood. And so basically did just tiny little needle, drew it out, compared it to the other asymptomatic side, because it was an active trigger point sample, and then looked at that interstitial fluid, him and his team. And what they found were like 23 different chemical mediators of inflammation were elevated in that around that tissue of that trigger point compared to the uninvolved side. Things like substance P, interleukin 6, interleukin 1B, norepinephrine showing vasoconstriction, all in there. So, yes, there is evidence that this stuff 100% is in there. And this study, kind of put a stamp on fascial pain. I'm old enough to know that prior to that, there were a lot of doctors out there that still said that myofascial pain syndrome, tender points, trigger points, fibromyalgia, it was a psychological condition. That there's no evidence because we don't see it on X-ray, we don't see it in the bloodstream. You're just faking it. And all of you who can feel it, you're just faking it too. You're being kidding by the patient. So this proved that there was a actual chemical cause to that pain. All those substances were already shown in gazillion studies to cause pain, and people stopped saying that it was a psychological condition. However, what was missed with this study that's been, again, cited all over the place is that what did it show? It showed that there was trapped inflammation. Okay, that is the problem. So people were still on the surface, popping joints, giving them stretching, do your core stabilization and all these things. And they missed the key part about this is that how do we get in there? How do we find that? And how do we get it out of there? Okay, that was the key thing about this study. And by the way, J.P. Shah, how did he come up with that idea to do that study? He was a patient of mine, and I was able to fix his chronic pain using the technique. And as a researcher, and he was actually a clinician as well, he's like, what the heck are you releasing? And that was my hypothesis. So I went down to the National Institute of Health, and I talked to all these world-renowned researchers, and I told them what I thought. And they basically said, well, no one has a better theory, so let's check it out. And so Dr. Shah published it, his team did it, and made Dr. Shah world famous. And he rarely gives me credit, so I got to give him some crap about that. All right, moving on.
Brian, connect those last two slides, going over the interstitium back to the patient case that we just watched.
Oh, yeah, okay.
One of my favorite videos that we actually show, throughout the curriculum. One, I think it's hilarious how the guy, it's like even 6 weeks later, his brain still doesn't believe that he can bend over because he still bends over with his arms like back here like this instead of reaching to the ground like any other human would do. But it's just such a dramatic change. And the other, well, do that first. And I have another follow-up question on that, if that's okay.
Okay. So what Kyle wanted me to zero in on in the case of Vince there, what was the inflamed structure? And as I said right before we had rechecked his mobility, it was inflammation of the anterior and posterior, longitudinal ligaments of the spine. And so particularly his posterior longitudinal ligaments were very, very restricted. And that is why he had such a lordosis. He couldn't, reverse his lordotic curve. And then there was some myofascia, true muscle problems, and, a la kind of Myers chains. If you've done the anatomy trains, those muscle pathways were also inflamed. So I did releases, if you want to call it that, for the spinal ligaments and the myochains. That's where the inflammation is. We're going to use surface tender points, which we'll go through in a bit, to tell us that that's where the problem is. So again, we can't get into all the assessments, but just realize that the tender points, which I'm going to talk about, are a surface presentation through a little reflex arc of the deep stasis. Okay. So in that video, it was anterior, posterior spinal ligaments and the myochains, which are some things we're going to talk about right here.
So the pre-post sort of a change that we saw, do you think that was partly due to the fact that he had dysfunction from all of the other systems already peeled off and he was sort of just left with ALL, PLL, myochains?
Yes. Yeah. So, we don't want to give people watching the impression that, every single person that comes in, no matter how many systems are involved, no matter how chronic they are, that it's a one and done as far as one session. That's not how it works. So, that was a case where when I assessed him, I saw he was like, through the assessment, he was like a pure myochain and spinal ligament case. The reason I videotaped it is because that's one of our courses. Okay. So we have all that in the same course. So I went and grabbed my secretary and I said, hey, come video this guy while I work on him, because he's a pure case and we don't get to see pure cases that often. So it was a pure case of
Yeah,
that.
it shows how significant those dysfunctions can be too in limiting range of motion and causing pain. I mean, that's
Yeah, we'll show everybody. I have a slide in here, Kyle, of now a lot of you who are experienced, you'll say, well, where did that positive straight leg raise come from? Leg raise test come from? So that was a dural sign, okay? And I'll show you in a second the anatomy of the spinal ligaments and how it really connects right into the dura. So there was a neurological effect, even though it was a spinal ligament treatment. Okay, so this whole paradigm is it's just applied anatomy. If you're somebody who loves anatomy, loves science, you're going to eat it up because the whole thing is based on as much anatomy, as much science as we can connect to the outcomes. Okay, that's really it's been my passion my whole life. All right, so let's talk a little bit about tender points before we go into some specific ligament things. So again, looking at some relatively recent research, 2007 and later, there exist what are called dorsal root reflexes. And the other concept, and we did a Facebook live on this whole concept of neurogenic inflammation and convergence. So this is a key thing if you're a manual therapist or a therapist of any kind. You have to understand that when a structure is inflamed, and in this case, they're saying the inflammation is around a vessel, or we could say it's an organ, like it's an intestine. And that nociceptive signal goes in to the area of the dorsal horn. What happens is that inflammation in that area goes back out neurogenic retrograde to all the other sensory neurons that meet at that same place. So you can get shared inflammation from the deep structure to the skin. And there's research that says, just like the statement right here, all spinal neurons that receive nociceptive input from the viscera, vascular, and musculoskeletal structures also receive input from the skin. So there is a patch of skin that's going to be impacted by every nociceptive input. And that is the surface tender point. So the tender point is not the problem. The tender point is the surface presentation of the deeper problem. In medical terms, we call that, scientific terms, we call that secondary hyperalgesia. It's a secondary inflammation from the primary inflammation, okay? So the process is not to go digging your thumb into this or rub an ultrasound on that or whatever. It's to find that and drain it, and then this will go away. The other thing I want to say about tender points, and it goes back to Dr. Jones, the originator of Counterstrain, it really sets Counterstrain apart from every other manipulation. I've trained in high velocity, muscle energy, so many things in my early 20s. But until you have that tender point to tell you definitively, aha, that's what's wrong. And number two, something to monitor the effectiveness of your treatment, it's kind of guesswork. But with the Counterstrain, we treat it until that tender point is gone. And that tender point is only gone when the source inflammation is gone. Okay, so that's just the beauty of Counterstrain. We fine tune our treatments and our drainage techniques till that tender point just drops out, the tissue relaxes, and it disappears. We wait till it dissipates. So it really is the only tool to really say, okay, I found it and I got it and I drained it. Okay. Any questions there, Kyle? Anything else I should touch on?
I mean, it's by far the most specific diagnostic in manual medicine, and it's something that Dr. Jones initially tapped into to start mapping out some of the dysfunctions that he was treating, and then you've taken that to another level with however many tender points and dysfunctions we have now, 1,500, whatever it is.
Yeah, this is actually, we have a 3D model where class by class, you can load your tender points on the interactive model. And I just pulled up a couple systems and took a screenshot. So these are surface locations. You'll see they're color coded because they're color coded by their source. So for example, green are related to veins. These are epidural veins, these techniques you actually learn in the beginner class. And then like yellow, these are nerve projections. Okay, so various nerve projections. Some of these are sinovertebral nerve projections from the disc wall. So, you actually see they're really all over the place. And then you can fade that muscle and see the ones that are on the bone level. There are many, many, many on the bone level as well. Okay.
I know this is
Right.
a complex question, but maybe for some of the skeptics that might ask, well, how do you know? How do you know that tender point is the triangular ligament of the liver? Or how do you know that tender point is the spinal extension vein? How would you?
Yes. I'm actually in the process of writing an article to answer that. Okay. So I actually have an invitation into the International Journal of Osteopathic Medicine Masterclass, which is an invitation-only category to write up how I've, basically correlated all of these tender points into real structures. But it uses, lots of three-dimensional anatomy, lots of segmental neurological connections. You have to know your anatomy, and also something called, inhibitory testing or touch inhibition.
Yeah.
So if you've taken a lot of osteopathic classes, somewhere along the way, you may have learned that if you have two restricted segments, for example, T5 and L5, and they're both stuck. And by the way, feel free to try this in the clinic tomorrow if you are able to motion test.
Yeah.
And you can put pressure on one and then check the other one for mobility. And then put pressure on the other one and then check the next one. When you find the segment that's causing the most nociceptive input, and there are some that do it more than others, like C1, C2, C3, T12, C7, T1 and coccyx for specific reasons. You'll see the other ones just drop out. And so basically sensory input causes a gating mechanism that shuts down while you maintain the contact, the muscle guarding reflex. So all that sensory input knocks out the muscle guarding reflex. So the one that knocks out the most segments is basically the place you should start. But it also works on its projected tender points. So I was able to go to a tender point in the arm and say, I think this is related to that deep spinal restriction, and I can pressure the tender point, and if it unlocks, that was the tender point that's connected. Okay, so it's called inhibitory testing, and they have articles out now as to how that works. But anyway, I literally it's about a 4,000 word paper to describe how I named all these.
And these are
hopefully I'll get it through publication.
Yeah, and then these are very advanced skills that that you've utilized over X amount of years in your development. But I think it's amazing what we've done with the curriculum now too, and that we're teaching those skills and including those skills in our entry level courses too, which is it's elevating the level of new student that we have.
Oh yeah, 100%.
To the degree of some of them are starting to have just amazing results beyond really what they are should be doing, I guess, with the techniques that they have. So it's really cool to see all those being included.
Yeah, and again, I think sometimes practitioners, you'll say, "Wow, if something's this powerful, I'd have no patience." I've actually heard people say that, and I'm like, "No, no, 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 no. It's the opposite." You get a person like Vince, who already had 4 surgeries, saw a bunch of therapists, had the epidurals, saw the acupuncturist, and then in a very finite period of time, give someone lasting relief. I promise you, he'll be back next time he hurts something else. And by the way, we saw him a few years later for a torn meniscus. His back was still good, but he's going to send everybody he runs into at the Christmas party. So no, don't worry about having business once you get good at this technique.
Yeah. Yeah.
And it's very rewarding as a practitioner. I mean, you really can, you don't get so frustrated when you have, multiple systems of different dysfunction you can assess. You have the ability to look at central mechanisms and peripheral mechanisms, and you're able to make sense via a diagnostic process of very complex cases. It makes it very rewarding and way less frustrating. A lot of people get out of PT, and simply because we weren't taught techniques that were powerful enough to deal with the complex cases that we see every day, and they just get frustrated. They just get out. And if you start down this curriculum, you'll start to see your success rate go up, and you'll start to love what you do.
Yeah, you may discharge them faster, but they'll send you 20 patients in return.
Exactly.
I do have
and if they get hurt, they'll be back.
Yeah, a question that popped up here since we're on the topic of inhibition. Is TI, is touch inhibition, is it consistent for every patient?
So there is a paper out talks about multi-receptive neurons and how one neuron can branch up and down multiple segments. Having said that, it is pretty remarkably consistent. Has anyone mapped it out further than what I did here in the curriculum? I don't know. So for example, I found a new treatment for some adipose tissue. By the way, adipose is vascular. It's part of the fascial continuum. It's innervated. And I kept seeing via our assessment something popping up on the scan for the adipose of like extremities. And then I cleared all the axillary stuff, and I cleared, all the adipose tissue we have in our class. And then I realized through some inhibition that what unlocked the segment and what unlocked the scan was the elbow. So then I went in and, pulled up near net, and there's, some really deep fat pads, in the posterior and deep in the cubital fossa. And then I, pressurized that, inhibited it, shut off the scan, and it fixed the T2-3 segment is what it fixed, because it's related to the sympathetics of the upper extremity. And then I treated it, and then I checked it on several people over the last 3 or 4 days, and it is locking up the same spinal segment every time. So yeah, they do. So we don't necessarily equate this down to every single segment that it locks up, but the process via the tender point and the other things we teach you, you'll know before you go poking around, very likely where those key tender points are. So yes, there's a long way of saying they branch all over the place and can have multi-system impact, but when you get down to one tiny little local structure that's not super powerful, like the dura, it can lock up just one very specific segment.
Good.
Good. Okay. So this is a little schematic that I drew that is just trying to give you guys an idea of how counterstrain works. So Dr. Jones figured out many years ago, he would kind of fold over things, decompress things, go in the direction of slackening, go in the direction of decompression of the painful tissue. And then if he held them there over time, things would just start to progressively relax. So I've kind of taken it to, again, an anatomical correlation level that we know exactly what structure, what depth. Am I going for median nerve? Am I going for the axillary, artery? And we literally just decompress that structure. And when you do that, because of the anchoring, filaments that are elastic into the valves of the lymphatic, when you create this shortening, those filaments open, and you create a suctioning negative pressure, and it starts to suck in all the fluid that is trapped in the interstitium as you maintain that. So we literally decompress and hold, and you'll start to see that tender point sensitivity drops, muscle guarding reflex relaxes, the motion restores, and we just hang out for about 45 seconds. Dr. Jones used to go 90, but the specificity of this newer version of counterstrain, 15 to 45 seconds is all you need, because I've now named where this stasis area is. So you'll go right at it and do the glide that we talk about. So that's what we mean by drainage or release. Okay, it's getting this trapped inflammation out of there. And then again, the paper talks about how cytokine exposure could be from infections, trauma, surgeries, causes TGF beta 1 to be expressed. Then the connective tissue tightens, and you can block all these pre-lymphatic channels. And so as you start to drain some of these cytokines out, then that TGF beta 1, starts to drain out, and the fascia literally relaxes. And Robert Schleip, he's a famous, therapist in fascia contraction, fascia congress, et cetera. A lot of you guys know who he is. In 2019, he took TGF beta 1 and dripped it directly onto human fascia and animal fascia, and it instantly contracted. So fascia does have contractile cells, really all tendons, muscles, ligaments, vascular fascia, neural fascia, meninges, it's all contractile. And so you actually can have a tight nerve and a tight vessel, okay? It's not all just skeletal muscle. All right, so let's talk a little bit more about the musculoskeletal. So a lot of you guys are out there doing a lot of musculoskeletal stuff. Now, what Kyle and I were trying to say as well is, realize, again, through the muscle guarding reflex, a lot of the muscle tension that you feel is a secondary thing. It's just a reflex guarding a deeper problem. For example, let's say I strained my brachial plexus, which is a neurovascular problem, and I yanked it, in a football game. My upper trapezius and my neck are going to contract to shorten it and protect it. So you can't go into the upper trapezius and stick a little needle in there and expect that brachial plexus swelling to go away. Okay, so we would come in and literally slacken up the whole, axillary fascia and the nerves themselves and drain that out, and then the muscles would just relax. Okay, having said that, muscle problems do exist. Myofascial pain 100% exists. They have very strong nociceptive tissue, the outer layer of the muscle epimysium. So myofascial does exist. So this would be a treatment of a muscle pathway. Now, again, many of you know, some of you may not, that Myers, he basically dissected, all the myofascia and Anatomy Trains books, back around 2000. And he realized that muscles themselves don't, in isolation contract, and then the central nervous system puts them all together in a big functional string. They're actually functionally connected, okay? So this is, for example, what he calls the spiral line, where you have this kind of semispinalis capitis and some rhomboids and serratus, and then kind of an external oblique, linea alba, internal oblique, TFL, all the way down the ITB, perineals, all the way down under the foot. And it's literally connected across the body like that. You can dissect it out. So what does this do? Well, when this unit contracts, it gives you a nice rotation. Okay, so this is a rapid rotation, connected pathway. You might, doing crunches or sports, what have you. So instead of treating each muscle in that area individually, what I did, years ago is I just applied the Jones concept, the shortening concept, to the entire chain. So I basically shortened the entire pathway up from one area to the other, and I can monitor any of the diagnostic tender points along that pathway. So right here at the insertion of the serratus, there's a big kind of strong insertion at the anterior inferior scap. I can monitor that. There's a nasty tender point on the bottom of the ninth rib in that anterior axillary line. It's all part of the same spiral line. And on the opposite tensor fascia lata, there's a nasty trigger point. So we could monitor any of those and do just one position held for 90 seconds after fine tuning. And that's the position. So here I decided to spiral her, shortened upper TFL, and then I decided to monitor the tender point on the serratus. So I could have chosen to monitor this one in this position. I could have monitored the ninth rib, or I could monitor the serratus. But in the end, this whole thing turns off in one 45-second release. Done. And then you move on to whatever its complement is. We'll often see a right-left balancing act between dysfunctions. So this is a case where this is a muscle problem. So muscle treatments could be effective, but unless you understand that these are in these long connected chains, and I would challenge anyone to knock that out, all those trigger points, faster than 45 seconds. Okay. So again, no pain, position, hold, and you won't see that one again. You will not do that release again in that patient unless they re-injure themselves in some future time. Okay, that is the carryover of the technique.
It's a higher quality release for the entire chain rather than just a temporary or partial release for part of the chain.
Correct. And if you didn't understand that, and you can monitor all three, tune in the serratus, fine tune the leg a little bit, make sure they're all gone. And that ninth rib one, by the way, is the sharpest one, which isn't really in the Myers books. Once they're all down, 70%, you hold it for 45 seconds, they'll all disappear. Okay. So when we say counterstrain's one and done, a lot of people say it's one and done. Per dysfunction, you'll treat it once as a therapist. It doesn't mean you can fix everybody's complaints in 1.5 hour session, but you do not have to redo things. You will never see ever in a counterstrainer's notes, treatment as previous. Okay. That is never the case. You'll see, I didn't do anything I did last time. That would be the one statement you could put in there, but I did this on the second treatment. Okay. All right, let's look at another one. Now that's myo chains, and we could go through what do we have in there, Kyle, in the myo chains? There's 29, I think like 28, 29 different myo chains. There are also myo chains I found that go from some of the upper viscera pec area all the way down into the pelvic floor. And they're not even in the Myers book. So I once I started mapping them out and seeing where they showed up in our assessment, it ended up, there's a lot of them. And
are you including cervical TMJ?
Yeah, I'm going all the way into even the eye. They're even, extraocular muscles. I'm not even counting those. So
there's a 30. Yeah.
Yeah, there's over 30 of those. Okay. Now, just to give you the content, again, those of your practitioners, how much content do you get in one class? You get all of that in one class. Plus, you're going to see all the anterior longitudinal ligaments, all the posterior longitudinal ligaments, and all the ligamentum flavum we're about to talk about is all in one class. Okay, so people say, gosh, there's a lot of points, but you come out with a lot of points taught in each weekend. And it might take you, advanced practitioner might take them 6 weeks to, integrate that. Someone else might take 2 or 3 months to integrate all those techniques. But once you own them, then you can come back and learn another system. Like, okay, now I want to learn how to treat the nervous system. Okay, so let's run on to spinal ligaments. So here's the anterior longitudinal ligament. There's your posterior longitudinal ligament. Anterior longitudinal ligament really goes from C1 all the way down to sacral 2. If that becomes restricted and contracted, again, all fascia contracts when inflamed, then it's going to give you a flexion moment or component. So you'll flex, okay? It can be one segment. It could be several segments. If you're a joint, trained practitioner, you'll see that spinous process is prominent. There's a restricted PA, posterior anterior mobilization. It's an FRS restriction in osteopathic terms. That's what you get. So rather than mobilizing it, manipulating it, muscle energy, what have you, we will shorten and fine-tune each side of that anterior longitudinal ligament, hold it for 45 seconds, and it'll disappear. And then again, that particular segment will not need that again, okay? Signs and symptoms, again, loss of extension, you present with a kyphosis. Obviously, if someone has a kyphosis in their thorax, they can get impingement of their shoulders. There's so many things you can see. Loss of cervical lordosis, loss of lumbar lordosis, and this one feeds into straight leg raise, but some of the ones we're going to talk about in a second do even more, okay? But again, one of the things that we saw in Vince in that video, I did some of the anterior longitudinal ligaments, all right? So what would a release look like? So I picked a thoracic location. Now, let me get my zoom out of the way again. I really want to make this just one here. Okay. Looks like it's going to be Kyle showing up. Let me see if I can pin mine here, Kyle.
That's like showing up as like a blacked out screen for me anyway, Brian. So I think
Oh, can you see us at all? Can you see me at all?
I see you, yeah, but just minimize that. I think that's going to be more other people's settings. Yeah.
All right, I'm trying to stay on the screen here some, but all right. If they're seeing what I'm seeing, I'll be on the screen there. Okay, so the tightness of the anterior longitudinal ligament, and in reality, the ligament is not this defined. It blends into the periosteum, and it blends right in to this costovertebral joint, and this whole thing becomes tight when you get a ALL dysfunction, let's say of T3 or T4. So that ends up projecting a tender point onto the lateral aspect of the tubercle. As the rib gets pulled anterior and in, that the rib tubercle pops out, becomes rigid and tender. So that is our diagnostic tender point for the ALL, anterior longitudinal ligament. So then I want to shorten. So I flex, side bend toward, rotate toward until that loosens up and goes away. Maintain that position for 45 seconds. And then that T4-5 segment, now extends. Okay, it really is that simple. And again, you could use that one technique at every thoracic level. Same pattern, just localized to that particular level. So that's ALL. Again, flexion components, we can restore extension, which many of you know that how many people come in flexed. Let's look at the posterior longitudinal ligament. And again, these are some things we go into in beginner class. We'll teach you the ALLs of the thoracolumbar and PLLs of thoracolumbar in the beginner class, and then you get much more in depth when you get into the spinal ligament and myochain class that we're talking about here. So PLLs, what would you see with a PLL? So now we're talking this side is contracted. So this is what puts people in extension, okay? Can give them a lordotic posture. Lordotic in the neck, forward head, for example, hyperlordotic. That's what you saw Vince's lumbar spine was hyperlordotic and he couldn't reverse his curve until we released it. So now we want to extend it to shorten it and drain it. And that is done like this. So these are the lumbar projections. And this is a back view of the right leg. And the tender points are on the posterior lateral femur. And this is the corresponding level, if you motion test, up from L1 down to the coccyx. This technique actually works all the way down to the deep dorsal sacrococcygeal ligament, which can give you coccydynia and some dura stuff. But this is on the back or underside, if you will, of the TFL. So this is what people spend all their day foam rolling, okay, or digging on, but they're projections from the spinal ligaments. So what I'm going to do is lay my patient in extension to shorten it, side bend toward, so this is left side bending for the left side, and then I lift the pelvis, which is rotation of the trunk toward as I go pelvis way. And that will turn off these tender points because they're coming from the ligaments. So now those distal things in the ITB that everyone thinks is an ITB problem is actually a muscle guarding reflex. It's a projected tender point from the deep spinal ligaments. Vince had that very, very badly, as you can imagine. So this allowed his lordosis to restore when we saw him bend over. His hamstrings also relaxed. And you'll say, well, why did that occur? And here's the answer. Actually, we're going to go into here. I jumped a slide ahead, but I'll show you guys. So this is a shot of what is called an epidural ligament. So if you look in the spinal cord, this is your dura. This is CSF. This is your ventral horn, dorsal horn. This is spinal cord. And then anchoring the actual dura and spinal cord inside the canal so it doesn't get injured are these little ligaments that are called epidural ligaments. Well, it turns out that, I'll go way over here. Turns out that this ligament right here, this is your PLL. So when the PLL is contracted and inflamed, it actually pulls on the dura. So when that is dysfunctional and shifted forward and extended, you get dural irritation. And that shows up as a positive straight leg raise. Okay, person doesn't need surgery. They don't need another laminectomy. As a matter of fact, this guy, as you saw, what did he say? He had 4 laminectomies. So they decompressed the nerve root whole, but they never fixed the epidural ligament and the PLL. So he felt no better, but the doctor then holds up his x-ray and says, look how big your nerve hole is. You should be fine. But that's not where the problem was. Okay. Now, I'm not saying that surgeries are never needed. Okay. Because that's not true. But many people are taken to surgery unnecessarily because, there are nociceptive lupus from other things. Okay. So anyway, that simple PLL technique could restore your lordosis, fix your forward bending, help your sciatica. And if that extension component goes away, it also, by the way, opens up the foramen, the vertical space of the foramen, and can truly decompress a disc bulge. All right, or help stenosis. Let me show you one more here. I'm going to go back. Last one, Ligamentum Flavum. This is a really, really cool technique that, as far as I know, we're the only one in the world that understands what this ligament actually does. Would you say that's true, Kyle?
I mean, you see it on diagnostic imaging reports talking about it hypertrophying and things like that. But beyond that, yeah, it's clinically doesn't seem to be talked about too much.
Yeah, so we know that hypertrophy of the ligamentum flavum, which is this ligament right here that attaches lamina to lamina. It's a one-segment ligament. It's not like the ALLs and PLLs here, ALL and PLL, that go the whole way down. So they're segment by segment by segment. They not only run right by the cord, it also has a very strong attachment. I'm going to go back to that slide. And I'll show you the ligamentum flavum right here. This is LF. It also attaches very, very strong into the area of that entire dura. Okay. Clinically, LF is very, very special. What it does is that it creates, I really am getting annoyed by my own screen here. It creates a irritation of the dura in the area of the interlateral column and intermediolateral column, which is the autonomic area. Very specifically causes vasoconstriction it causes a synovitis. It causes a segment-specific synovitis. So, for example, the T3-4 ligamentum flavum will give you synovitis capsulitis of the glenohumeral joint. It is a major, major player in frozen shoulder. The T4-5 ligamentum flavum will give you capsulitis and synovitis of the first CMC joint, thumb capsulitis and arthritis. Okay, so not only is it improved flexion, but it has a secondary capsulitis, and every segment has its own. So, for example, the TMJ is due to ligamentum flavum, capsulitis of the TMJ of C1, C2, C3, all focus into the TMJ. So you can use this technique on any capsulitis in the body. And it is just one of the most incredible before and after changes that you'll ever see clinically. Now, if anybody says, I get this a lot, you say, well, what research is this? Yeah, I'm the one doing the research. Okay. It is repeated clinical outcomes is actually research. And I'm telling you the loop, but no one's been able to really, measure this as yet. But I'll show you in a video in a second how this is predictable and how fast you can do it. But anyway, we'll teach you that one as well. So in the spinal ligament class, Maya chains, all the way up into the C7 level, so they're down. ALLs, cervical, thoracic, lumbar, all the way down to coccyx, ALL, PLL, and ligamentum flavum for your capsulitis at every level. And this technique actually works below L5, for some different anatomy, and can actually work on capsulitis of the midfoot. Okay, it can work on capsulitis, all the way down into the MTP joints of the toes as well. So anyway, this is the example of the ligamentum flavum technique for the glenohumeral joint. Okay, so it is a extension, side bend toward, rotate away of the trunk, not rotate towards. It's a little different than PLL. And the diagnostic tender point is the coracobrachialis muscle. So if you've ever taken a frozen shoulder and tried to rotate them, if they've got this capsulitis, that coracobrachialis, pops right out. And if they're a version that is ligamentum flavum driven, this is a very simple technique that you can do to, gain a lot of rotation without pain. Okay. So again, if, I used to, back in the day, I was practicing in 1990, we would be cranking on these people and, apologizing, so those days are gone in the modern manual medicine.
What are some other applications for the dura, Brian?
What now?
What are some other applications for the dural connections with these spinal ligaments, as far as types of presentations beyond capsulitis for LF, but beyond spinal pain?
Yeah. Very strong in the world of any kind of slump testing, any kind of it just depends on what you want to call that. So if you're just saying the impact on the ALLs and PLLs, okay, coccydynia is 100% one. But if you fix the tension on the coccyx, which the PLL goes all the way down onto that into the filum terminale, that can have a widespread segmental improvement due to that multi-receptive neuron thing I was talking about. Coccyx is one of the segments that I call key segments. If you inhibit the coccyx when it's dysfunctional, you can feel, 15, 20 segments relax in the spine. We actually had a participant in foundations class, our beginner class, last year, that I was just demonstrating touch inhibition in the beginner class. And I happened to see a patient, one of the participants, whose spine was stuck all over the place. And so I did a quick assessment and realized he was coccyx. That unlocked everything. And at the end of that day, it's the end of day one, I said, would you mind coming on camera so I can show how this coccyx inhibits and frees up all these segments? And she was like, yeah, sure. So we used her as our demonstration person. I laid her on her stomach and I went through and she was stuck all over the place. And when I got to the coccyx and I pressurized it, you could see every single segment all the way up to the neck. They all improved and a lot of them just disappeared. So I happened to notice when I grabbed her coccyx, it was just actually a bone dysfunction. It wasn't the PLL. So I did a really quick release on it. And then all the segments all improved. And it was, maybe a minute of treatment. Well, she comes in the next morning. And again, I really didn't even do a full assessment. I just said, yeah, you need coccyx. And she came in and she said, it was unbelievable what that one release did. I said, what did it do? She said, she goes, I had chronic quadratus lumborum pain, and it would bother me when I slept, and it was gone. She goes, and I have bilateral trigger fingers, and both of them are about 50% better. And all I did was the coccyx. So the point being, these connections that are happening, from peripheral into the pain sensing areas of the brain and affecting the central nervous system as well, you really can't, outsmart them or even memorize them. You have to have a process that says the stasis is here, you fix it, and you reassess. And that's how the curriculum is designed. It is just, you go through the process, it tells you what to do, okay? You treat it, and then you reassess. And it's pretty amazing in the end that you end up treating things you would have not thought to treat.
Yeah, the diagnostic process, if one thing that I've gotten from it is I'm treating the coccyx way more than I ever was before, just because of its impact and shutting down so many other vertebral segments. Um, I do have a couple questions here that I think are worth kind of clearing up. Sherry's, I think you've been mentioning that you've been monitoring something during our release. So Sherry's asking what exactly you're monitoring. Is it the tender point? Is it the cranial scan? And what are you monitoring it for?
So the monitoring, when I'm using that phrase, is the diagnostic tender point, which Dr. Jones described as tense, tender edematous masses about a centimeter in diameter. Now, in science terms, in their article I'm writing, we would call it a TART change. The tissue texture, abnormality, asymmetry, range of motion, tenderness, it's the TART findings. They're all the same. So where it's tender, it's also stuck. So as I'm doing my manipulation and my glide, my decompression with one hand, I'm monitoring for the change in the other hand. So I want to feel it soften, and then when I check it, it should be getting less tender.
And then Nancy here had a question uh, about the ileocecal valve, and that as she's treating that, she does find that it occasionally comes back. What is she missing?
Mhm. So the first thing you want to do is make sure that the actual scan, visceral scan came back, okay? Not simply the tender point without the scan. And what that gets into is there are central, meaning central nervous system, cranial bone, even dura, things that are in the central nervous system that create, entire systems and subsystems of about 30% tenderness. And if you happen to have one of those things, it turns out, some of the area of the temporal bone can drive the viscera, make tenderness in all the viscera. You will see that the tender point comes back, but it doesn't come back all the way. And it doesn't scan local anymore. So our assessment will say it's not there. But when you check the point, you're like, well, still a little bit of something there. And the person's like, yeah, it still hurts. It's not as bad as it did. But got to go back to the assessment. Did the body say treat the periphery? If it doesn't say that visceral problem is there anymore via the assessment, then don't treat it because it's coming from something central. So that's why sometimes in your toughest patients, you find, hundreds, if not thousands of tender points. So my entire personal caseload is mostly all out of state. They fly in for 3 days, some of them even out of the country. And I do most of my work in these people in the brainstem, central nervous system. First I clear that component out and then I clean up the body because there's so much, secondary stuff in this super, super hard chronic pain population, particularly if they've had head injuries or Lyme disease where the inflammation got into the central nervous system. So for anybody who's a current counterstrainer, if you think it came back, check the scan. Okay. If it doesn't say to treat it again, which it likely won't, move on. This is somebody with central stuff.
You can have central stuff and then autonomic stuff as well.
Right. It could also be that's a very good point. It could also be a T10 sympathetic will also give you a point, but it'll scan sympathetic. It scans nerve. It doesn't scan viscera.
Right.
Okay.
Right.
So don't treat things that don't scan. And beginners, it takes a while to understand that concept.
And then I have one of the participants, Rhea, asked, "Why do we use cranial scans for all the treatments?" And that's why. That's why.
That is why. So the
Eliminates the false positives.
cranial scans tell you the primary area of stasis of hyperalgesia, not all the secondary stuff. If you just poke tender points, you'll be, inconsistently successful. And in the toughest cases, you will not be successful. Okay. So that was the idea. You have to learn the assessments. So it becomes very surgical and you never do anything twice if you learn the assessments properly.
But in those tough cases that maybe these patients have developed different compensatory movement patterns, are there patterns something that we have to address after treatment, or
yeah, if you're come from a movement therapist paradigm, you definitely use those skills. You can always use any of your current skills. I have to tell you though that the muscle guarding reflex, which is the tightness and the pain input, either conscious or at the conscious level is why people are altering their movement initially. So if you can get to that underlying nociceptive input to the central nervous system, help some of those proprioceptors balance, and then get rid of the tightness, your job of retraining is much, much easier. But yeah, always can use some of your, retraining skills at the end and gait training, ...
All right. Want to show the LF demo here?
Yeah. So anyway, last video here. This is somebody that, again, it was a really nice example for this class. It's in the musculoskeletal class. This was a lady who, until she walked in, I didn't realize she was coming in that day. She actually went to my church, and she looked like 3 different problems: a neck problem, osteoarthritis of the neck. She said it was on X-ray, arthritis of both thumbs, and bilateral frozen shoulders. And what it turned out to be was almost exclusively ligamentum flavum. Her neck was stuck from the ligamentum flavum, her thumbs from the T4, and her frozen shoulders from the T3, and then a few other little ligaments I cleaned up. But what appears to be, oh boy, you're going to be a project, let's start with your neck, and then we'll work on your right shoulder, left shoulder. It was really all just LF. We call her LF lady.
So this is Jane we just assessed, and she's had a pretty significant limitation, neck motion, and then she's having progressive pain in her thumbs and a history of frozen shoulder on one side, both sides?
Frozen shoulder on both sides. I had one arm first, and then a year later I had the other arm.
Had the other arm. Go ahead and turn to the right, okay, and to the left. Okay, you get pain there in this mid-back area?
And on the sides.
On the sides of the neck, okay. So what we found was a significant ligamentum flavum dysfunction, and that is responsible for frozen shoulder and also for capsulitis of the thumb. The T4 level is on the left side is dysfunctional, which associates with the thumb, and this is your bad thumb, right? So if she abducts her thumb, so go ahead and bring that out to me. And you have pain right there? Okay. So that measures at just about 40 degrees of abduction on that side with pain. And let's do this side. Okay, bring that out as far as you can. Okay. And then this side, she's measuring over 50 degrees. Any pain on that side?
No.
Okay. So that's a mild capsulitis forming due to ligamentum flavum on this side. And then we're going to look at her shoulder, which was T3 dysfunction on the right. Laying your back here. This is a loss of external rotation. Okay, feel that pain right there? Okay, so she's coming in at about 60 degrees there.
Yeah.
Okay, versus her other shoulder, which has 80 or 90 degrees. Okay, so again, the T4 ligament flavum affects the thumb, the T3 affects the shoulder. We're going to treat those and then reassess. 15 minutes later, and what we found were all musculoskeletal dysfunctions. We found ligamentum flavum at C5, C6, T3, and T4, as we knew. Found the anterior longitudinal ligaments at T1, T2, C3, and C4, and then the upper extremity T1 and C7 muscle chains, and we treated all those. And again, we're going to see how this has impact on the neck, the thumb, and the shoulder, which look to be unrelated problems. So first thing let's do is take a look at the thumb. So go ahead and pull open again for me. Okay. And we're going to go back. First of all, is there any pain there?
No.
None in the thumb. And then we'll look here at that alignment. And she's at almost 60 degrees now. So from, I believe we were at about 40. Okay. Much better. And to see that compared to the other thumb, open up both at the same time. Okay, and you can see those guys. Actually, if anything, this might be slightly further right now than the other side. And it feels good?
Feels great.
Feels great. Okay, so thumb of capsulitis and potentially progressing to arthritis is looking good. Let's come over and look at the shoulder. And we'll get in here, take a look at our shoulder external rotation now, which was limited at about 60 degrees, and now we're just going to drop. Okay, how's that feel?
Good.
Feels good, okay? So instead of hanging up and about here, okay, it's dropping all the way down. So big improvement in shoulder external rotation, and the pain stopped though, right? All right. And then sit back up, let's take a look at the neck. See on the front there, King. And she also, of course, one of her main complaints when she came in was also neck pain. So let's turn left for me. Okay, very good. Any pain?
No pain.
And right for me. Okay.
Good.
Very good. So again, 3 different complaints, like a developing thumb arthritis, a residual frozen shoulder, and neck pain, all treated with musculoskeletal fascial counterstrain. All right, thank you.
All right. So once again, that was a patient I think maybe I saw her one more time, and then she's good. And like I said, I knew her and she didn't need any additional treatment. But those are the kind of things where you want to understand some of these reflexive secondary impacts of some of this deeper work. Okay. And I think that's another really good example. Whereas ALL and PLL, we could kind of extrapolate the local segmental changes we would think, but then you may not have understood what that was going to do to the straight leg raise until you understand the anatomy. And then ligamentum flavum, once again, also pulling on the dura through those vertebromeningeal or epidural ligaments, gives you this whole different secondary autonomic synovitis / capsulitis. And you can actually feel when you do the T4 treatment and you got your finger on the thumb or the shoulder, you can just feel the capsule just kind of pulses away, and you can feel the blood flow, and then it just drains and just loosens. When you would mob that, you might feel it loosen a little bit, and then 2 days later it seems like it's right back. But you don't have to mob it. So even if it is arthritic underneath, you're not using force, so you don't irritate the arthritis, and you get rid of a lot of that vascular flow issues. Perfusion is the real word, in and out, that caused the arthritis and the synovitis. Okay, so can you cure all parts of arthritis no matter how far they are? No. Okay, people 100% bone on bone. There's a point of no return. So, but moderate to severe, early, 100% can get those people feeling really good.
We talked about the spinal ligament dysfunctions as sort of being this fascial contraction where the ligaments are tight and going to be restricting motion in the opposite direction. But what about in cases of ligament laxity? Is a question I'm getting, specifically C1, C2.
Yeah, so CCI basically.
Yeah. What are you seeing?
Yeah, so we don't have the ability through these reflex arcs to tighten things up. Okay, so you don't get more to prolotherapy, things like that. But many cases of hypermobility, you could even say instability minus like a severe car accident or something, they are due to adjacent hypomobility. So when you look at someone with CCI, many times their cervicothoracic junction, their C2-3, many of these things are quite locked up. And we can also calm the nociceptors all around that segment with no force. So you can go into someone's CCI and follow the process and use these very gentle glides, but then really focus on freeing up and giving them motion from everywhere else so that their C1, C2 doesn't have to do all the work. Okay. And I even had a case relatively recently, and again, not one I could write up because the doctor, I didn't get the stuff from him, but the patient had CCI scheduled for fusion, and she had headaches, migraine. She had so many neurological symptoms, and she was the sister of a patient I was treating, and she said, my sister's going to get a fusion, and she told me all her symptoms, and I'm like, I don't know that I can stop her instability, which they saw on DMX, on the dynamic X-ray, and the guy's like, you need a fusion. I said, but I can promise you, in her current state, with all those other symptoms, she is going to be a mess after that surgery, because you're taking this massive nociceptive, CNS inflamed presentation. She had vagus symptoms, she had nausea, she had migraines, and then you're going to go in and inflame the bejesus out of it to fuse that segment. I said, let me at very least, one of us at the clinic, do an hour or two of counterstrain on her and just clear all that stuff out. So if she goes to surgery, at least she's going in with a fresh, non-nociceptive and non-inflamed state. Anyway, long story short, she became asymptomatic fully. And she's like, I don't want to go back to that guy. And I said to her, I said, he said that you were so unstable that you need surgery. So I want you to at least go back to him, tell him you had this new kind of therapy, and say, look, I'm feeling great. Do I still need to have surgery? And so she went in and did this, and she again related on a follow-up visit the conversation. Basically, he said, well, that's impossible. You can't be symptom-free. And he said, I'll prove it to you. You're still unstable. ran the DMX, and it came back negative. And then he said to her, it must have been a false positive test. To which I said, did you call him out on that? And she said, what do you mean? I said, he just told you that per that test, you
The first
100%
one was
needed
false.
surgery. And then on a whim, he's like, oh, it's a false positive.
That's funny.
Anyway, so he said, no, you don't need surgery, obviously because the test must have been false the first time versus the treatment having worked. But now, again, not saying that CCI surgeries are never needed, but, again, treat what you find. It's a non-force technique. So it's, people with Ehlers-Danlos, babies, people with, osteoarthritis, people with osteoporosis. It's a non-force technique, just try it.
See if and there are a few questions coming in here. I mean, do you want to cover some of the conditions treated here first? And because some of them are actually about that, and I'll jump in if I want you to expand on one.
Yeah. So, gosh, obviously each one of these is a lecture, but the point of this, if you're just glancing at these conditions, is that, it's a very large scope. Okay. So the scope of treatment with counterstrain expands beyond the world of pain and neurological stuff, venous things, for example. I'm just glancing at one here, seizures. Okay. So you would think just by that name, wow, seizures, you can't do anything for seizures. Well, it turns out that seizures don't happen until the pressure in the brain reaches a certain threshold. Okay. That you have a seizure. So if you know how to treat the basic drainage pathways out of the brain, like your jugular vein, vertebral vein, epidural plexus, okay, external jugular, facial, pterygoid plexus, all these things that are pathways out of the brain, you can lower the pressure below the seizure threshold. So many people around the country that are even just have lymphatic clasps under them have been able to do great things for seizures. Okay. So, again, post-concussion syndrome, again, central nervous system inflammation. But I could literally have a conversation about every one of these, but, meniscus tears down here. So what do you mean? Cartilage? You can treat cartilage? Yes. It turns out it's fibrocartilage, and have been discovered myochondrocytes. So the cartilage itself is actually contractile. And when it gets inflamed, it gets very, very tight. And you'll get, joint line pain, like a cartilaginous feel, restriction. It's meniscus. And you can even see inflammation on MRI. But if you release that, the meniscus gets its mobility back 2 to 3 millimeters. It relaxes. And even in the case of a so-called tear, I don't know, Kyle, what's your experience? I would say 50% of people with tears still become asymptomatic. Okay. Maybe higher. I'm probably being quite conservative there. But if you get a massive bucket handle tear and the knee locks, okay, those people can still end up in surgery. But yeah, you can treat cartilage, you can treat viscera, digestion, cognition because of inflammation in the brain, chronic regional pain syndrome. The article that I'm putting out, they said I could do a case study on my counterstrain method article. So I'm actually doing it on a patient who had 4 surgeries and bilateral chronic CRPS in her legs because during one of the surgeries, they stuck a screw into her called a coina. They tried to fuse her pelvis. And, it was a case where Dr. Jones used to say, if someone has more than 3 or more surgeries in one area, don't take the case because there's so much permanent damage. She had 4 surgeries in one area. But I just decided, she walked in one day and I'm like, the next person walks in who's got a visible problem is my case history. So, because I needed to do questionnaires and videos all the way through. And, her CRPS, both legs is essentially gone. Her functional questionnaire, over the 4 sessions or so went from 70% to 11% disability only. And that's because she hasn't tried running and jumping, but she said she's not going there because she wouldn't want to risk where she's gotten to. But, a lot of these conditions are considered incurable, irritable bowel, right? Treat the viscera, treat the sympathetics, treat the perfusion to the gut. Irritable bowel syndrome, it's a syndrome, it's not a disease. So it has dysfunction underlying it.
Yeah, it's a collection of dysfunctions. Some other ones I have on here, snapping scapula syndrome. It's an interesting one there.
Yeah, snapping scapula syndrome. That one, it's been a few years since I've seen that, but that's a combination of some of the tightness of the serratus and the asymmetry of ribs combo. So you get a lot of those ribs that are dysfunctional, they're torsioned, and then you got a tight serratus and it's kind of popping over those rib angles. Sometimes it's even asymptomatic. It just freaks people out, but yeah.
I've actually found that one to be connected to GI mes specifically.
Oh, for the thoracic, the rib stuff's mesentery. Yeah, okay. But I said there's always a thoracic component, and then there's a scapular.
Because the people that have it, their symptoms will get worse after they eat something inflammatory. And if
Oh,
you,
yeah, right.
if
Yeah.
you
So
cue them up to that, they'll start to notice it.
yeah. So anyway, a lot of the viscera, the pleura, the mesentery, the pulmonary root can really change rib alignment and flexibility as well.
PTSD, anxiety, we can schedule a different live for that, I think. But we do have resources for that. The Bridge Back Project is a nonprofit that is doing some research and does some treatment via a naturopathic doctor for some of our first responders and military that are coming home with PTSD. And then a couple of people here asking about pelvic floor dysfunctions as well, different prolapses, rectocele, diastasis recti. Have you treated a lot of pelvic floor stuff?
Yeah. Again, those are all different causes, but let's just say that the laxity disorders that are post-pregnancy are probably the toughest, because you can have some true, tearing and some permanent laxity. As far as your, like today, I had a patient, just using today as example, who has a neurogenic pelvic floor, and she's been seeing many doctors, many therapists, and she also had rectal pain. She had perineal itching, and I targeted it yesterday, and she came in today, and she said her sciatica was gone, and all of her perineal itching was gone, and she just had one little area around the anal sphincter that felt tight. And then I did an actual visceral release of the anal sphincter. And when she left today, she said that felt better. So again, multi-system, but I did go up and do a lot of the innervation. For example, the S3 nerve root is a direct branch into levator ani and all those pelvic floor muscles. So she had a very inflamed S3 nerve root, and her S4 nerve root into the coccygeus was also extremely inflamed. So people working on the muscle once again, but it was a neurogenic. It was nerve inflammation in her case. But when people have this massive laxity from like a really bad pregnancy or, those can be very tough. Yeah. But I would say, true, you want to treat those people first if they're going to have surgery, clean them up, let them have surgery, and then clean them up again.
Yeah. Actually, I had an interesting patient myself that came to me with pelvic floor dysfunction, multi-system, like you're saying, had rectocele, and I believe they measure that in grades. So she was grade 3. I think it's 1, 2, 3, 4. I'm not a pelvic floor therapist, so if you are, don't quote me on that. But I treated her multi-system, and she's relatively asymptomatic now. I mean, she's back to doing high intensity workouts, and a lot of those initial complaints are gone. I did have her see a pelvic floor therapist recently, though, just to do an internal exam because she hadn't had that done in a long time, and for some other kind of stuff that she was dealing with. And I asked the pelvic floor therapist how was her rectocele, and the pelvic floor therapist said, like, wow, like it was pretty bad. So it was interesting to me, though, that the symptoms that she was complaining of that were associated with the rectocele had resolved significantly, yet the visual appearance of the pelvic floor hadn't changed.
Yeah, and again, a lot of these things come down to, can you get people asymptomatic? We all have dysfunction. We all do. And a lot of times when you think you got a person, pain-free, you just took them over the nociceptive threshold. You took enough stuff out that they're asymptomatic. But when you start to check people with this multi-system paradigm, you'll see, there's nobody walking around with no dysfunction. We all have a certain amount. So the real goal was to get people asymptomatic.
Let's see. All right, what else you got for us, Brian?
Oh, so yeah, I was just going to talk about the scope of the work again. When you are doing a multi-system paradigm, taking you out of this musculoskeletal system, lots of people are working in that system with some pretty good success, things like dry needling. But now we start working on things like PTSD. You start working on, things where it's the autonomic nervous system, CRPS, peripheral neuropathies, things that are nerve. You can't treat that with a needle. You can't treat that with an ultrasound. And digestive disorders, chronic fatigue syndromes and seizures. The scope of the work is very, very large. And a lot of times counterstrainers, end up doing, as you and I do, you end up being, kind of a cash practice where you treat, hour and a half patients, finite number of visits, taking the worst cases and, doing nice, high quality work. And, people absolutely want that because they don't want to, be put in a gym, put on a bike, with 4 people in the gym at the same time and told to exercise, away their peripheral neuropathy. So in the end, we find ourselves treating a lot of things that aren't musculoskeletal as a counterstrainer for sure. If you're interested in going down this road in this paradigm, the entry level class is called Foundations of Fascial Counterstrain, and we will go through the basics, of the rationale, the phys, and start in on the assessments. And I have a proprietary motion test of the cranium that really tells you what systems are inflamed. And we start learning that on day 1. We teach you some of the other things like touch inhibition. And then you do learn, 40 techniques and basically, 5 different systems. So you're going to come out of foundations class with a multi, system sampling of the curriculum. And you can just go right in and start checking people for visceral stuff, start checking people for spinal cord swelling, start checking people for ALLs and PLLs. And so basically give you a nice foundation, that's why it's called that, to really understand the paradigm, see that it works, and then you come back and start going down the curriculum based on your caseload. If you're somebody who's a pelvic floor therapist, for example, you're going to want to get into the viscera, you're going to get into the nerve classes, and obviously, because you may already have some pretty good myofascial skills, but, what about treating the spinal cord, or what about treating those neurogenic varieties? So you may find you go in the curriculum to areas that aren't musculoskeletal if you're, somebody treats migraines or things, much more.
Yeah, and we'll put in the chat, if we haven't already, we'll put links up for the course information pages for the Fascial Foundations course. We do have one coming up at the end of February this year. And the other thing that we'll link to is if you are brand new to this technique, we do have a welcome page that has additional resources for you to help you continue to learn. One of them is Brian lecturing even more in depth on the physiologic rationale. Another one, if you haven't experienced the technique at all, either as a patient or seen it done as a practitioner, is Brian does a technique demonstration that kind of walks you through the process and technique procedure of what the actual technique looks like. And then last, there's a surface anatomy video, again, to start to get you learning and prepare you really for the curriculum, while also showing you the specificity involved. It really is a surgical level of palpation that's required, and it starts with just knowing your surface anatomy. So we should be linking those now if they weren't linked already. And then if you have taken F1 and are in the curriculum too, the techniques that we've talked about today, this evening, as a reminder that they're in the MSK spinal ligaments course. So the musculoskeletal spinal ligaments course, which is also coming up later this year. I think it's in the spring that course is being taught too. So anything else, Brian?
No, I would just say, some people are a little bit at times intimidated of the size of the curriculum and, just realize that when you start using these techniques, you're going to clean up the patients with these techniques that you learn in a class or 2 or 3, and then you kind of go back to, what you were previously doing. And over time, this indirect multi-system paradigm becomes, it becomes your tool, becomes what you do. And you always, do ergonomics and, patient education, but it just takes over what you do. Even the naturopathic, group, they're all taking this. These are naturopathic physicians that in their states, they can do IVs and they can do all kinds of things. I talk to them, a year or 2, 3 into the curriculum, and I'm like, so how much naturopathic stuff are you doing versus counterstrain? They're like, oh, I use counterstrain. That's all I do. So even the non-PTs are it's replacing what they do because they can see the change in the organ systems and perfusion of the gut. So Yeah, it's a journey, but
It's a
I
fun
was
one.
actually having a conversation today, and it was somebody who wants to send a practitioner, and they said, well, what kind of person really loves this work? And I said, perfectionist. I mean, if you're the kind of person that you hate when that person's coming in and saying they're no better, and the person you can't figure out keeps you awake at night, this curriculum is for you. Okay.
Yeah.
If you're the person who, you're more interested in, having exercise sheets and just watch them do their thing, this is not for you. I mean, you gotta like to get your hands dirty, you gotta like to figure out the problem. And, it's for the people who just love the science of it. And, that's really who loves this stuff.
I was going to say, I think, selfishly, the people that love the science of it, and I mean, how many students do we have that say that they learned more from this curriculum than they have in any of their previous schooling?
Well, actually, I'll say one more thing before we go. On that note, so Kyle and I and the Jones Institute in general, we gave some of the osteopathic professors a discount rate to come into the foundations class because, weirdly, when Jones passed away, it's not weird, that entire profession said counterstrain's over, and the osteopathic physicians in the United States just stopped taking it. So, I as a PT continue to move it, and we teach osteopaths, all over the world and in France and Australia. But the American osteopaths were just like, Jones is gone, we're out. Well, anyway, 20, 30 years later, some of them have, gotten wind of where this has gone. So we invited them to come take, these are the manual medicine chairpersons of DO universities that we invited. And three of them were at the end of foundations class last year. And they were all sitting around talking, and I was cleaning up, and they all said, that they really, really enjoyed the class. And I said to them, I said, is compared to your osteopathic curriculum in college, is this foundations class below, at, or even above the level of your college class and curriculum? And they all three simultaneously said, it's above. I said, we don't teach what you teach in beginner class, even in osteopathic school.
Yeah.
Yeah. So you better like the science. That's all I'm saying. But the point is, it's like, you guys are already shooting questions at us. How does this mean? Why is this? That's what we love. That we want to try and give you those answers the best we can.
Yeah, and then that's what we cover as early on in the curriculum, because the faster we can answer those questions for the students, again, we're introducing skills and concepts now, and just doing things a little bit differently. That's expediting the level of student in their development. It's really, really fun to see students coming back to their second, third class and telling us stories about the amazing results that they're having with their patient caseload. So. On that note, Brian, thank you so much for your time. I know it's getting late there on the East Coast, but we really appreciate you being here with us and answering some of the prospective students and current students' questions, and helping us all elevate our clinical practice. And thank you guys all for being here with us too, and taking time from your evenings. And we're going to sign off now, and we'll see you down the road.
All right. Bye, everybody. Hope to see you at a class.